that it was in 2001, and actually I missed the diagnosis at 24 weeks of age, which I probably would not miss today, because there's the very typical frontal horns. We had just thought that this was a dilated ventricles, but only after 29 weeks of gestation, we also saw that this was indeed a hemimegancephaly. You can see the asymmetry of the whole cortex, and you can see these polymicrogyri in the frontal areas. But the typical rounding of the frontal horn is very, very, very typical for this hemimegancephaly. And when we were all looking at the brain, when we were focusing and thinking, we missed this child. This fetus had so many other abnormalities. He had a preaxial polydactyly, he had syndactyly, he had all kinds of hamartomas in the abdomen. I guess if at that point in 2000 we would have looking into the whole body and used the MR for that, we would have probably not missed the other abnormalities, and this was also proven on histology. This is what polymicrogyra looks. You can see that the whole cortex is traveling around and causing these beautiful, I think, picturesque abnormalities on these images. And this is what it may look like postnatally. Sometimes there's an associated cyst in it, but you can see the abnormality. And always, always look at the right frontal horn, which has this funny looking abnormality, and this helps you in the diagnosis. And this is still another case. It can have many shapes and sizes, and you can see what hemimegancephaly can look like and the association. Now we're going into the second group of the neuronal migration group. Okay, and within it is also a very complicated group. We have three various, this is the old definitions, the lissencephaly subcortical band heterotopia, the cobblestone, and the hydrotopia. Again, this has all changed, but these are the three major groups that we need to at least know or be able to describe them. And what is classical lissencephaly? It's graded according to the degree of gyri. It's a thickened cortex. It's separated from the deep layer of the neurons by a cell-spared layer. These are broad, flat gyri with shallow sulci. It's usually in the frontal and temporal lobes, and the temporal lobes are less affected. And they are either very severe ones, which are RA gyri, and usually it has the very typical ones, has the typical 8 shape. When you look at the brain, it looks like it has an 8 shape, but these are the very classical lissencephaly. Now, just for a quick glance, you don't have to learn anything of these. They are now subdivided according to the genetics, and there's an anterior predominant, a posterior predominant. Each one is having its own name related to the gene that's described. So that's the reline, and there's the variant, and it's become, and this is just to give you a quick glance of LIS1 and DCX and the 2x1, and I really don't want to go into it. And just to show you, and I think it's again important to see the relation between ultrasound and MR, and this is some of the work and help of Daniela Pryor, as Laurent had mentioned before. When you look at the abnormal cortex, even in very young age, when you're at 7 weeks of gestational age, which is not the usual age that you perform fetal MR, the brain is very symmetric, and this is normal to be symmetric at 7 weeks of age, gestational age. By 22, 23, you become very asymmetric. So if you're in the range of 22 weeks of gestation, if you are still very symmetric, if both hemispheres are symmetric, and there's also an increased subarachnoid system, you should start thinking that there's some abnormalities. It's a very subtle abnormality, and in these cases showed to be lissencephaly also. At 33 weeks of age, it's easy to make this diagnosis. If you see this figure of 8 abnormality, then you know you're talking about lissencephaly, very thick cortex. Here, it always helps us to see that there's also absent corpus callosum, the interhemispheric fluid, and also abnormalities in the cerebral hypoplasia. This is still another case performed at 25 weeks of age, which is not so easy to make the diagnosis. With still at different cases, I think I will, for sake of time, pass it. This is a neonate with profound microcephaly. This diagnosis was not made prenatally. Okay, you can see the typical, this is it's supposed to be very typical for tuba A1A. I think I saw only 2 cases, or at least identified seeing 2 cases. Again, the typical flattening of the cortex. This is already a neonate, this figure of 8. The signs of the absent corpus callosum, so the parallel ventricles, and you can see that there's no corpus callosum, but this is the very typical brainstem abnormality that you are seeing. Is like a Z-shape abnormality, and the abnormal cerebellum. This combination should always let us think about tuba A1. It's not necessarily that we need to know it, but at least if we can describe all the various malformations that we are seeing in a context of a microcephalic patient. This will help our geneticists, look specifically for a gene rather than doing a whole search for it in the various areas. Okay, and this is still another one, ARX, but again, this is really getting more into the various abnormalities. The second group within it is the cobblestone malformations. This is formerly, it was called Lysencephaly type 1, type 2. Okay, and this is a very confusing group. There are many, many different appearances. It can look like many different things. There's the posterior pachymeria, and there's an anterior. Again, it's cerebellodysplastic cyst. There can be abnormal myelinization in central areas. And again, we're seeing the corpus callosum and septum pellucidum. So there's a lot of overlap between these 2 groups, and it's, again, very difficult to differentiate them. This is a case that from Teleshomel, and it's actually the only case of Walker-Warburg phenotype at that time, and this is, again, like 7-8 years ago. Look how typical it looks with the abnormal brainstem. Look how typical it looks to the previous case, the cerebellar abnormality. And this case was followed as, this is a very legit family. They thought it's only going to be hydrocephalus rather than any cortical abnormality. And the cortex abnormality was only identified later in gestation. So we're going into the 3rd group. We're still in the neuronal migration group of the heterotopia. And heterotopia is again a little bit problematic. What it means is a collection of normal nerve cells in abnormal locations. So they have migrated, but they're sitting in various areas. And usually they present postnatal with seizures, developmental delay. So these are nodular regions that are iso-intense with gray matter. It's very important that they be iso-intense with gray matter on all sequences. And that is something that sometimes people confuse white matter abnormalities with heterotopias. And periventricular nodular heterotopia is secondarily to a non-ependymal abnormality. It can become subcortical when you do have an abnormal transmental migration, and it may sit in a very laminar band heterotopia. And then it looks very much like the second group that we had talked about, Lysencephaly. So sometimes it can be very confusing to see the difference of the very symmetric heterotopias that have a band type and compare them to a Lysencephaly. And actually Barkovich has taken this group and put it back into the Lysencephalic group. Okay? So I'm just going to give you one interesting example of periventricular heterotopia. It was a filament mutation, but the story was very interesting. This was referred from the north, and actually one of our best sonographers in the north area had sent this woman. She had already 3 daughters that were normal, and at 25 weeks. He had sent her before mild ventriculomegaly and a megacisterna magna. He had thought, and that's why he sent her for MR. I don't know why he sent her so early in gestation, but what I found, and he did not see it, was these little nodules all over. When you look at it carefully, you see that these are subependymal nodules. And you know, I went to the family. It was a late night, as it always is, a late Friday night, and they said, look, on top of seeing the periventricular heterotopias, there's also, there's not only this megacisterna magna and ventriculomegaly, there's also these heterotopias. And they said, oh my God, we have to, we have 3 daughters, we don't want to deal with anything. And then And I didn't know, and I sent them back to the referring physician in the north. That's the way that we practice in Israel at this current time. I talked to the neurologist, to Professor Sagi, and she said, listen, is the mother okay? Can you please ask the mother if she has any abnormalities? And I said, okay. And I called the mother up, and she turned out she has epilepsy. And I said, what kind of epilepsy do you have? She says, no, I have a normal MR, I have nothing, I have that. The husband did not know she had epilepsy. And I said, please read to me, they're living in another city up in the north. I said, please read to me the MR. Lo and behold, on the MR, she has periventricular heterotopia, which is very typical. Whoever knows this syndrome, there's a hereditary subependymal heterotopia is associated with megacisterna magna. And I guess I'm getting here into the most important thing. Not everything that we see abnormal really means that there's going to be an abnormal consultations. And all of us who are dealing with prenatal imaging, I think it's very important to do it in a multidisciplinary fashion. You really have to know that this family, no way in the world I could have convinced them to continue the pregnancy. The baby was a fetus. She could have probably developed maybe epilepsy at 40 weeks of, 40 years of age. There was no reason to stop the pregnancy, but they were very adamant once that the woman did not tell her husband that she had epilepsy. It was really quite crazy, this whole situation. So I think it's very important to know about these cases and to do all the consultations in a setup of genetics. And these are just a few more examples of diffuse in the older 5-year-old. This is how they can be. And if you think that's complicated, now there's new genes that actually show that these two things can come together. There's been a nice review by Barkovich and another that actually the heterotopias go with the subcortical and